Good afternoon. My name is Peter Molyneux. I am the England lead for the Global Leadership Exchange in Mental Health, Substance Abuse and Disability. My pronouns are he, him. This afternoon, we're running a network conversation looking at the subject of mental health in schools. The purpose of the session is to give us an opportunity to talk about the importance of school as a place to support the mental health development of children and young people, to share the importance of providing early support and helping children and young people to build resilience, and to hear about the various efforts being made to achieve this, and then also to explore the different approaches being taken to support schools in bringing this about. I'm delighted that joining us this afternoon, we have three excellent contributors. We're going to start with Bronwyn Dunnicky, the Principal Advisor at WRRO. Then we'll hear from Nancy Kelly, the Director of the Division of Children and School Mental Health at SAMHSA, and then from Catherine Roach, the Chief Executive of Place to Be. So we're going to start with a recording that Bronwyn Dunnicky did for us.
Kia ora koutou katoa, ko Bron Dunnicky Taka Whenua. Thank you so much, Peter, for this opportunity to provide a pre-recording on the Mana Ake school-based mental health wellbeing initiative in Aotearoa, New Zealand. I've got 15 minutes. It is very early in the morning here, and I hope I can give you a good overview of the program and some of our input into it to date. So my name is Bron Dunnicky. I am one of the principal advisors at Whāroto. I'm going to give you a little bit of an overview about our program as well and where it fits into this process. If you have any questions, then given this is a pre-recording, obviously I've got my details at the end of the slides and you can contact me directly. And so this program is called Mana Ake, and Mana Ake in Te Reo Māori in English means stronger for tomorrow. And so who is Whāroto? Whāroto is a workforce program, and we're funded by the Ministries of Health here and predominantly, and we have a number of contracts around workforce development for the infant, child and youth mental health sector. And we have a lot of contracts, a lot of support around resourcing with the sector, with tools, trainings, and lots of other ways of actually making sure that the people in the workforces are well equipped to be able to offer programs to infants, children and young people. And some of the specific programs that we get involved in, we support the youth primary mental health and addiction workforce across a number of different programs there. We support learning around eating issues, eating disorder, and we support the development of the peer youth lived experience workforce here and offer a lot of support for the youth forensic workforces as well. We do a lot of foundational learning. Some of that is also focused within trauma-informed care, youth alcohol and drug and mental health concerns, assessment tools, and we provide some regular learnings at lunchtimes for the whole of the sector here. We do a whole lot of work around quality improvement, and that includes the implementation of the choice and partnership approach. We've developed a competency framework for the infant, child and youth mental health sector, and we do regular stock takes in terms of what the workforce looks like in New Zealand. And we do a lot of sector engagement, and we do that with the support of our youth advisory team, and we have a youth lived experience team who are part of our broader team. And this particular initiative that we support, Mana Ake, sits within our supporting parents whānau, who are family and schools in New Zealand. So as well as this program, we do a lot of work around supporting people in their skill development around family engagement and parenting programs. So who are we? Who's here in Aotearoa, New Zealand? We have a population of just over 5 million. 69% of families are two-parent families, and 31% are one-parent families. 18% of children identify from a range of ethnic groups, 75% European, 24% Māori, 11% Pacific, and 7% Asian. A bit of background in terms of the Mana Ake program here. There was a need identified following the earthquakes in Christchurch, New Zealand in 2011, and there's a lot of research that actually identified that some support around resilience for children and families at that school age 5 to 12 to 13 would be a great benefit here. The program was launched in Canterbury in 2018. It's been supported by successive governments here. It's funded through Health New Zealand, and it's now been rolled out in 6+ districts. So essentially the idea behind Mana Ake is that it provides a new approach to delivering school-based mental health support for that 5 to 13-year-old population. Some of that holistic support is sought through providing direct support to tamariki who are children experiencing social, emotional, and behavioural challenges. It looks to clarify pathways, making it easier for schools to get the support that they need, and support schools to enhance their school environments for children through the provision of a wellbeing lens, and looks at also service sector improvements through greater collaboration between agencies. Some of the concepts behind Mana Ake, it is cross-sectoral. All of the programs are very much based through a co-design and developmental process, inclusive of lived experience and cross-culturally. It looks at the development of collaborative partnerships. It's very much developed in primary level services and with a strong partnership to specialist services as well. Most of the programs have a collaborative governance model. It works very much on a light touch philosophy of coming in, supporting children and families as much as they require to get back on track with their resilience, and supporting the communities in schools as well with resources to actually ensure that wellbeing can be a focus for them. Some of those resources, obviously, the funders, a huge shout out to the ongoing support from Health New Zealand in particular to continue to support and roll out these programs. The resources also include the governance groups. Within those governance groups, there's always a focus on practice support and program support. And the people who work within the Mana Ake programs come from a variety of clinical and non-clinical roles, multidisciplines, multicultures, multi-skills, and come with multi-sector knowledge, which is a huge, huge benefit to the program. Another resource is a national website for teachers, which supports teachers and the broader school community in their understanding of wellbeing concerns for children and families. Most of the schools have pastoral teams, and the program is often a part of those pastoral teams and can support wellbeing knowledge in that way. Children and families are obviously the biggest resource of all in all of the programs, and a huge shout out to all of the children and families that have been part of this program over the years. The workforce development support is offered to all of the programs, their induction support through Whārauro, and again, we're very generously funded for that activity. This slide is so I know it's hard for you all to see, but essentially it speaks to the levels of support. So if you think about the partnerships, community partnerships that work together, the aim is to provide those, within those community partnerships, provide support at 3 levels. So providing, along the top, you'll see providing support for schools, for the community, and for children and families. And along the bottom there, you see the different levels of intervention, starting at that universal level, a targeted level, and an individual level. So some of those universal programs that provide that school-based wellbeing, some of the targeted programs that have strong evidence and are often group-based and are offered within the schools by the people within the program. And then the individual approach where where children and families are identified that may require that extra support, that is available through the program as well. So again, 3 levels of support, 3 levels of intervention. Some of the achievements to date from the program, there was a very much identified and welcomed support from the program following the mosque attacks in 2019 in Christchurch. With strong evidence that the program actually really does work, and provided a lot of support at that time for school communities, and also over time was able to provide support to the families, some of the families from that were involved in the mosque attacks as well. With the programs have received excellent feedback from school communities, children and families. There is growing evidence of enhanced relationships across the sector, so that's within the health and education, within the health sector, within the education sector, within other sectors, and across all of those sectors as well. The development of the programs has meant that there have been an excellent opportunity to get in early where there have been further incidents in Aotearoa, New Zealand, which have included floods in particular. The other achievement has been the upskilling of the broader wellbeing workforce. So the amount of support for workforce development has meant that there has been a significant increase in the opportunity for people to enhance their skills and knowledge in terms of supporting children and families across the whole of the country through this process. There's been the opportunity to enhance cultural confidence and competence as well, and there's been a strong focus on making sure that the programs that have been offered are well aligned and have a good reach within local communities. So it's been win-win-win. You can't see this well either, but essentially this provides some information on the range of workforce support activities that Whāroto has been involved in providing. What I can actually tell you there are things such as, again, looking at foundational training and looking at sensory needs in the classroom, motivational interviewing, looking at some cultural learning, understanding the school context, documentation, note-taking. There's been a number of intervention training, such as solution-focused, as I say, motivational interviewing as well, safer home visiting, professional boundaries, risk assessment, looking at some supervision for cultural learning, Lego therapy, safeguarding children in terms of child protection, cognitive behavioural approaches, group work skills, and so on. So you can see from that a whole range of learning activity, which has been then supported by some community of practice development and ongoing supervision. So that's a quick overview of the program and our support of the program at Whāroto. I know that it's hard to actually engage with a lot of that material because it was delivered fairly quickly. So if you have any questions, there are several people on our team that work within the Mana Ake initiative for the workforce development part of that, and any one of those could answer your questions, I'm sure. If you would like to contact me directly, I can either answer those questions for you or connect you up with the right folk to do so. So kia ora koutou katoa, thank you so much for listening. Ngā mihi nui, kia ora, rawa atu, thank you very much. Kia ora and good morning.
Really excited to be here. talking with all of you. And we really do hope that there's an opportunity to have a chat. I know after Catherine's that we can all just talk. Peter, I just want to put that little bug in your ear. I think it would be great just to have forums for conversations, you know, that people can bring, like, to talk more about how we've used peer support, family peer support, or youth peer support, or youth advocacy, or, you know, all those kind of like the components of it, to just break them down and say, we're struggling with this. And I think that would be great to have that, just that, like that sharing of the minds and the thoughts and the, you know, sometimes we can't suggest things. Jen and I can't suggest things here inside because people look us like we have, you know, cross eyes, but we could share with you and say, hey, but England says we can go ahead and do this. So anyway, I'm digressing, but I just thought that was really exciting to hear about New Zealand. And I had all kinds of questions and things I wanted to talk about. So I want to introduce Jennifer Traeger. Jennifer Traeger will be doing this presentation together. She is the Project Aware Program Coordinator. So I'm going to do a little lead into that, and we'll get going and stick to our 15 minutes. It's not my forte, but I'm really going to work on it. Okay, to start, the Division of Children and School Mental Health is everything children within SAMHSA, Substance Abuse Mental Health Services Administration, which is part of the federal government and sits under our Health and Human Services agency. SAMHSA is the smallest operating division in HHS, and we are primarily a grantor. So we grant money, we grant funds to, I'm just gonna say broadly, anything public, private, nonprofit entities. So schools, community organizations, hospitals, colleges, universities, tribal entities. We're across all states, all territories, and to do the work around substance use and mental health services, from early intervention all the way to treatment, and all walks of life, all populations. It's quite a big job for just such a small little agency. But anyway, we're going to start with trying to like lay the groundwork of why we need to pay attention to school mental health, and then what youth say works for them, and then what we're doing as an agency to try to continually tackle it. So we were fortunate that the youth risk behavior survey data came out from 2023. So that's fabulous. It's hot off the press. And as you can see, this survey data summary trends report, it provides data on health behaviors and experiences of high school students in the US. And it highlights students' behaviors in 2023, but changes from 2021 to 2023. And then it also shows the slide, the 10-year trend. So this report specifically focuses on, and the survey, it's done every 2 years, sexual behavior, substance use, experiences of violence, mental health, suicidal thoughts and behaviors, and then other important issues like social media use. So if you just looked at this, you would say, wow, we are, and you look from 2013 to 2023, it's worse. Things aren't looking good at all. In fact, things are looking much worse. But if you look at 21 to 23, you see that things look better. You know, albeit a little bit of marks, but so that's definitely a misleading trend in a way, but we're in the right trajectory. So we're heading the right direction. So if we break down that data and we look at just a couple of items, high school students who experienced poor mental health during the past 30 days and experienced persistent feelings of sadness or hopelessness during the past year. And we're going to look at demographics, characteristics, okay? And so as shown in the previous 10-year trend, like I just said, it continues to improve for some areas of adolescent health and well-being, including sexual risk behaviors and substance use. But unfortunately, the data shows that we just saw from 2013 to 2023, almost all other indicators of health and well-being in this report worsened. Data highlighted worsening trends in protective sexual behaviors, experiences of violence, persistent sadness or hopelessness, and suicidal thoughts and behaviors. And as in previous reports, disparities persist among students who identify as lesbian, gay, bisexual, transgender, questioning, or another non-heterosexual identity, which we label as LGBTQ+. LGBTQ+ students were more likely than their peers to have used or misused all substances, including in this report. They were also more likely to experience all forms of violence, signs of poor mental health, and suicidal thoughts and behaviors. So whereas we just actually have a brand new grant program, first ever, I believe, in the federal government, an LGBTQI+ family support grant. Just came out. There's 8 grantees. And let me just tell you, it is real in that just those grantees have experienced people hacking into their webinars, into their office hours virtually, and just like harassing them in a safe space. So it's something that we continually address and are very cognizant of, and it's incredibly important, and it's sad to see that it still continues to be a population that is suffering. So you see this broken down between sex, race and ethnicity, and sexual and gender identity, and females in both categories, in both of these 2 items, fare worse. In race and ethnicity are American Indian, Alaska Native, Black, Hispanic, multiracial, and even white, but fare worse. Sexual and gender minority, LGBTQI, is far worse off than your gender and heterosexual populations in both of these categories. So the struggle is real for our American Indian, Alaska Natives, and our LGBTQ+ populations. So then what could we do? What do the teens want us to do? What will help them most? I mean, that's where we should go, right? To get, like, instead of us creating these plans and programs, we need to talk to the people, like, what helps you the most? How do you want service delivered? So NAMI, the National Alliance on Mental Illness, conducted a poll in 2022 with teens. And they found through this poll that most teens are comfortable talking about mental health, but often don't start the conversation. They also want schools to play a big role in their mental health, and they trust the information they get from schools, but feel like schools aren't doing enough. I mean, we're sitting here thinking, I don't know how much more we can do. I feel like we're doing like everything. In their minds, we're not doing enough. So this poll is very small for our country. The poll was conducted between July 15th and August 1st in 2022. And it is based on a representative sample of 1,015 US teens. I mean, that's a really small population, but I think it is probably representative of ages 12 to 17. And these teens were recruited through their parents. So in my mind, what I said to Jen when I saw this, when we looked at this, I said, oh, so these are teens that are already talking to their parents. I mean, these are teens that have open lines of communication. The margins of sampling error is plus or minus 3.5 percentage points at the 95% confidence level. So yeah, they want schools to play a big role in their mental health. 56% say schools think that mental health matters. So they do know that schools care. They do know that we're thinking about their mental health and we care. 67% of teens, I'd like this at my job, think schools should offer days off for mental health. And I do know that there are some schools around the country that are like piloting that. And so among those who have sought information about mental health, 95% trust their parents often, 80% trust their teachers and other adults at their school, and 78% trust their friends. So they believe we care. They want information from us. They want help from us, from adults. But we're still falling short. It all should be noted that 64% feel the world is more stressful now than when parents were their age. About 1 in 6 report experiencing specific negative emotions all the time or often. And I just picture like school hallways during class transfers, like 1 out of 6. And 1 in 4 have been diagnosed with a mental health condition. Those are staggering numbers. Okay, so we know they want our help. So what could we do? What's the best approach. I don't know the best, but how should we tackle this or continue? So this is an advisory from the Surgeon General, the U.S. Surgeon General, and we wholeheartedly agree. This is the approach. Even before this advisory came out, I'm going to say this is the approach, SAMHSA, that we've always taken, that everybody, and this is supports our colleague in New Zealand just spoke about, everybody has a role to play. We know that there is much more to be done, and supporting the mental health of children and youth will require a whole of society effort to address longstanding challenges, strengthen the resilience of young people, support their families and communities, and mitigate the pandemic's mental health impacts. And yes, we are still recovering from the impacts of pandemics, especially in our schools, with regard to workforce and with regard to loss of school time, loss of social skills from our young people, for our young people. We just did this is off topic, but I just did a review of a briefing that's going to be going out, and I actually heard somebody said we need to downplay the pandemic. That's gone. That's old news, and I'm like, no, it's not old news. It's still very much factors in how we need to help and support people. So here's what we must do. That's what I think we're going to talk to you about, how we are doing this in our upcoming slides. We need to recognize that mental health is an essential part of overall health. We need to empower youth and their families to recognize, manage, and learn from difficult emotions. We need to ensure that every child has access to high quality, affordable, and culturally competent mental health care. And we need to support the mental health of children and youth in educational, community, and child care settings. We need to address the economic and social barriers that contribute to poor mental health for young people, families, and caregivers. And we need to increase timely data collection and research to identify and respond to youth mental health needs more rapidly. Okay, so how are we doing that at SAMHSA? So one grant program that I'm talking to you about is Trauma-Informed Support Services. This is a fairly new program since 2022, and there's only 20 plus grantees right now, but this is a direct service grant program. So this is only schools, state education agencies, local education agencies, tribal education agencies, tribal entities, could apply for this grant, because we want, this is to specifically ensure that trauma-informed support and mental health services are occurring in schools. So this pays for mental health therapists. This pays for local community providers that they have to collaborate with as a requirement, provides those services. This is, I want to, as we go into the next one, Jen picks this up in the next slide. So I want to describe that how we approach our grant funding is just not, okay, so yes, it comes from the president's budget through Congress, gives us authorizing language, and then appropriates funds. And whereas sometimes it feels like a certain congressperson, senator might say, oh, I care about this, I want my name on this, or let's say an incident of mass violence occurs, which is devastating, and they're all of a sudden say, oh, we need to have this, we need to support this, more people need this service, and they'll like drop money into a bucket and then say, here, take care of that. Well, we know that doesn't fix it. We'll take the money and we'll take the grant program, but we work very hard to, and have conversations with Congress to make sure that what is funded and what we provide or afford to communities in our nation are connected and not just random standalone grant programs. So we always have our mind on that whole approach that I just talked about, that our grant programs connect. So this direct service grant program that provides direct mental health therapy, direct training, as you can see in 2023, this one grant program, 2 grantees, trained 5,291 school staff, students, and administrators, screened 34,678 school-age children for mental health related interventions, referred For services, 2,965. Now, for me, that directly connects to the infrastructure grant that Jen's going to talk about, directly connects to the mental health awareness training grant we have, directly connects to our early intervention, early infant childhood grant programs, connects to our children's mental health initiatives that provide systems of care, provides first episode psychosis, clinical high-risk psychosis support and funding. So they all connect. So while we have these individual programs, it's critical that they all work together and in unison. And we have grantees that might have pieces of all of these grant programs so that they're able to approach this holistically. One point before I turn it over to Jen, and she's going to talk about our Project Aware, which is the overarching program that everything we do is supported underneath, is something that's disheartening to me. But it just inspires me, inspires us to continue this work. So if we look at the number of children screened, and this is a great little snapshot of 20 grantees, okay? So this is 20 state education agencies or 20 school districts or 20 tribal entities together. They screened a lot of kiddos. But from those screenings, look how far it drops off to how many were referred. Now, one could say, well, that's great. Not that many kiddos needed referrals. Does that mean that? Because if we look at our data that we said 1 in 4, 1 in 6, something says that more should have been referred. This doesn't even, because we still struggle with documenting who accessed the service. We try as we may, but that would be following all these children to like, what is access? Did you do an intake? Did you do an intake and did you do 2 therapy sessions? Like, it's really hard to collect that data, but my sense is when we have tried it, that access number drops even lower. And that to me is where the real crux is. So it's like, we can do all this, but are kids, are families actually getting the services that they need? And so the more we do in schools, create these service centers in schools, I think the better chance we have of actually getting help to the kids. And with that, I'm going to turn it over to Jen Traeger to talk to you about Project Aware.
Thank you, Nancy. And I think that's a great segue into Project Aware, because I think what you're saying about making sure the kids are getting the services is really the importance of developing the infrastructure that needs to exist in order for the kids to get access to the services. So that's a great segue, I think, into Project Aware, because Project Aware is a program where grantees receive funding to develop a sustainable infrastructure in their schools for mental health programs and services. So it's kind of like, I think about TISS, the Trauma-Informed Services in Schools, as like part 2, whereas Project Aware is really part 1 in developing that sustainable infrastructure. So the programs and services implemented in Project Aware span the spectrum from promotion, awareness, prevention, intervention, and resilience activities, and then eventually develop those referral pathways to make sure that students are getting access to those services. So Project Aware has been around since 2014. Currently, we have 93 active grantees over 5 cohorts. We have 3 that ended, and grantees are awarded these grant funds for 5 years. Eligible entities for Project Aware vary from state education agencies, local and tribal, to state mental health agencies, hospitals, behavioral health organizations, and other nonprofits. So it's a pretty broad range of who is eligible for Project Aware. We have since recently expanded our eligibility. So we have cohorts that were originally just state education agencies and tribal, and then we expanded that to include more entities that could apply for Project Aware. Grantees leverage.
Jen,
yep.
Can I add one thing I want to say?
Yep.
So these grantees can ask up to $1.8 million a year. So they're awarded $1.8 million a year for 5 years. That's that. I mean, they don't have to ask for 1.8, but they can go up to 1.8. So I just wanted to say that. So they knew what the
Yep.
amount of money that they were working with.
Yep. Thanks, Nancy. Yep. So the funding that they get, they leverage their partnerships to implement mental health activities to ensure that students have access and are connected to appropriate and effective behavioral health services. So you can see here, the purpose is to build collaborative partnerships with the different entities in their community and implement these programs and services. And the hopes are that they'll increase awareness of mental health, substance use, and co-occurring disorders, increase the mental health literacy of all the adults that interact with school-age youth, and for the youth themselves, promote and foster resilience building activities to encourage mental well-being for school-age youth, provide positive behavioral health supports, make sure, again, connecting them and their families to the needed services, and increase and improving access to culturally relevant, developmentally appropriate, and trauma-informed school and community-based activities. So Project Aware is really a program that facilitates that relationship between state and local entities to support the integration of systems and programs to help create that nurturing school environment so that kids are feeling safe and healthy at school, so they have the ability to really thrive. So the next slide. So the implementation of the grant is based on this 3-tiered public health model. It is important that this whole entire implementation is really built on a culturally competent, linguistically appropriate, grief and trauma informed, and developmentally appropriate implementation to ensure equity for all children. So before they work on implementation, grantees will conduct a needs assessment to really understand the needs of the community, the strengths that exist in the community, and the gaps that may be there as far as resources and other things. They also work to develop an advisory committee with important partners, including youth and families, to support the implementation of the grant. So as you can see on the slide, at the base of the triangle are the collaborative partnerships. So when I see the slide, I think about really like that base as really the foundation, like what is supporting the work of this implementation. So the collaborative partnerships within the school systems, both within the school, those interdisciplinary teams, which I think was talked about previously, as well as in the school community, really help to provide the foundation for the grant. So at the beginning of the grant, as implementation is getting started, those developed partnerships really help to build the buy-in for the implementation of the grant, which is a really important piece to happen before grant implementation can occur. And as the grant continues, the partnerships are essential for grant implementation. So partnerships can be with community organizations, mental health agencies, youth serving agencies, organizations to provide the support. And the partnerships developed with the agencies really help to strengthen the work of the grant, help to tailor the work for the community specifically, depending on the organizations that they're partnering with. And it also really helps to support the sustainability of the grant, because the partnerships and the relationships that are built can really go beyond the life of the grant. So other important foundational aspects are that staff wellness and support, making sure that the staff is supported, healthy, providing the resources that they need, family engagement and youth voice, really engaging the families, training the families, giving them the information, tools, access, resources that they need, and then having the youth really be at the table as well and really hearing from them, what's important to them, what's going on with them, what suggestions do they have, because their experiences are a lot different than the ones that we've had growing up. So really hearing from them is really important as well. And then going into the 3-tiered model, that tier 1 is really that universal prevention. So that's really for all. And then, you know, as Nancy said, we have other grant programs that kind of support some of these. So our universal prevention and mental health promotion, we have a mental health training grant where grantees are getting resources to provide training. So that can support some of the work happening in Project Aware. So the universal prevention and mental health promotion is really a comprehensive mental health awareness program for youth, families, school staff that helps to increase that mental health literacy, really helps to kind of change the culture around talking about mental health, learning about mental health, and even accessing services. So each grant can kind of pick what fits for their community of what might they do to implement this tier 1 intervention, as far as maybe what kind of trainings, what kind of evidence-based or evidence-informed practices that they may do for this tier 1. And that just really provides the ability to train all. So there are some examples there. This is where maybe suicide prevention is happening, mental health literacy, social emotional learning, resiliency skills. So these are things that would happen for everybody in the school community. And that tier 2 is really the secondary prevention and brief intervention. So that focuses on providing services and supports to youth who may be showing some mild distress or signs of concerns. So this is early intervention, which may include small group interventions, peer supports, brief interventions, or mentoring. And so that's just helping kids maybe with friendship groups or lunch groups, or just really helping them to understand and developing social relationships, positive decision-making, problem solving, those kinds of things. And in this tier 2 would be the development of a process to screen and identify school-age youth in need of mental health services. So really, it leads into tier 3, but the importance of developing those, how grantees really think about and develop their referral pathways. So how they're like training, identifying, understanding when there's a need of concern, identifying the concern, and then really successfully developing those referral pathways, knowing the resources in their community so that they can then identify and ensure that kids are getting access to those services through those effective referral pathways. So then tier 3 is really for young people who might need more intensive services, and providing those intensive services, whether it be in the school or they're providing those referral pathways outside of the school. And that's where those partnerships really come into play so importantly, because if they have the partnerships with the community-based organizations, then they're able to get the young people connected to the services that they may need. And that's really where the parent and caregiver involvement is so important too, so that the understanding what's happening and how they can support those families to access those services. And then the other thing, just quickly for tier 3, is also being able to respond to crisis if a crisis occurs. All right, so successes and challenges. So just like any program, there's lots of things. So successes are building that mental health infrastructure. So as stated earlier, that's such an important part of doing that with the 3-tiered public health model, really changing policies. So creating policies and changing policies so that this is, when we talk about sustainability, the policies are a really big part of that. So if they have certain policies in place, this is just the way we do business now because of the work that we've done with our grant, then that really helps to sustain it. So they've built that infrastructure and sustained it. Maybe some of the staff that they've hired, they're able to hold on to that staff. And a lot of grantees have shared how valuable it is that they're talking at their state agencies, breaking down those silos, really collaborating with each other so that they're working together to make sure that kids are getting the help that they need, working across the LEAs. Some grantees have stated that they have to pick 3 like local education agencies when it's a state education agency, or the local is the grantee, but they have also then shared with other locals within their state of kind of like, this is how we're doing this, so that they can share like the good work that they're doing and use it as a model to expand it. And like I said, changing policy and hiring staff is such an important thing. A lot of states have requirements for training related to mental health, suicide prevention, and those kinds of things. And Project Aware grantees have a lot of times been at the table and have been able to kind of share what's important, use their data to show that what's important and how they're having an impact. So sometimes that has had impacted policies. Again, developing the partnerships at the state and local levels. And those kinds of things. Are we going across time so that we can, so I'll just go quickly to some of our data. So there has been, this is just 23 alone, that we have trained over 300,000 teachers, administrators, school support staff. So a lot of training has occurred. A lot of young people have been screened. This is just in 1 year. 297,000 plus individuals have been screened, and nearly 91,000 young people have been referred to services. And grantees collect this data, but they also collect qualitative data as well. They do a lot of focus groups and collect information from staff and that kind of stuff. So I'll stop there. I know we're running out of time. Always lots to say about Project Aware. I just want to say one thing really quickly. A lot of grantees have said how helpful it is to have Aware, like when times of crisis occurs too, because they have the infrastructure in place to just, connect students when they need.
And I just want to say that Peter has this slide deck in a PDF that, Peter, you're free to share, and these are
I will do.
different resources and stuff.
I will.
Thank you.
Thank you very much, Nancy, and thank you very much, Jen. And I think it was really important to get a sense of the infrastructure, and the way having that infrastructure in place is really important, but then the way in which that then works its way across to schools and to the end recipients. I think you brought that through really well. Thank you both very much indeed for doing that. So I'm going to move us on to Catherine. If I could encourage people, if you've got any thoughts, comments, questions, please do put them in the chat, but I'm going to hand over straight to Catherine.
Brilliant. Thank you very much, Peter. And it was absolutely brilliant to hear from Nancy, Jen and Bron. I think we're going to cover some similar ground, or hear certainly familiar themes as we go through our work here at Place to Be. So Place to Be, we are a voluntary sector organization. Oops, why is my slide not moving on? Let me see. There we go.
There we go.
So we're a voluntary sector organization working here in the UK. And we've been around for 30 years in this space. So we work very much across within schools, so in the educational environment, but providing a health service. So speaking very much the health language, and completely focused on children and young people. And there are three main things to what we do. One is actually providing services, and we talk about the whole school approach, which is something that we have built out and developed from initially providing just targeted work to over time and over the years, really taking that systemic approach to work with the children, the staff, the parents, the trusted adults all around the child or young person. So that's the first thing that we do. The second key thing is about the workforce, and building and developing a workforce that is skilled and equipped, drawing on evidence-based practice to support children and young people. And then the third thing that we do as an organization is around gathering evidence to look at and challenge ourselves and explore what works, and to use that and equally things that we think need to be improved, so that we can use that to drive policy and system change, whether that is at a national level or at a local level. And then if I take us right into our schools, so within either a primary school or a secondary school, so we're working with children from the age of 5 right up to the age of 18, with an emphasis on early intervention and prevention. So we started with the younger age group in primary schools, but over time we have built into the secondary schools, as that was really driven by the demand from school leaders who felt that our work was equally needed within the secondary school, the older age group. And here, central to our approach is both the child voice, so listening to what children or young people are telling us and accessing within our work, and also equity, diversity, and inclusion. So absolutely being focused on what is the makeup of the school population, within any community, and then challenging ourselves and looking at how can we work to ensure that our services at all their levels are accessible to all children across the community and within the school. And that is very much something that is a work in progress, and something, well, I'll come back to workforce, and that is so important in terms of children feeling like the professionals look like them and are from their own communities. So we heard a lot from the other two speakers on partnerships and collaboration, and absolutely that's essential to our work, and working in real partnership with schools. And that goes from working at school leadership level and helping school leaders, head teachers and school leaders, to think about what framework that they have to put in place a whole school approach, to then working with and supporting staff in the schools, because it's so important that staff are in a good place themselves and understand and think about what lies behind a child's behavior. And then also supporting and working with parents and carers, because we know there's limited value in making a difference for the child, or seeking to make a difference for the child in the school environment, when actually that being backed up and the support being in place for parents and carers to be able to also back that up and in the home environment. So in terms of the services then that we deliver within the school, we offer both, we heard a little bit about promoting good mental health and well-being, so the mental health promotion end of things, through to providing targeted work. So we provide on the targeted end one-to-one counselling or CBT-informed work, particularly in the secondary school environment. We provide group work, which is a trauma-informed group work approach, Journey of Hope, and also then really importantly, a drop-in accessible service that's available at lunchtimes for any child. And thinking about, you know, children in primary schools who share a worry or concern on their mind, and then get an appointment and come and visit a clinician within the school to work out. And that's run very much in a solution-focused way. It's key in terms of building resilience and helping children to develop solutions and build their emotional literacy. For parents and carers, we offer a blended approach, so both in-person parent and child coaching. So this is really for children who present with challenging behavior, and where we recognize that actually working in a structured, supportive way with the parent and child together can make an even greater impact. And then also based on that same approach, we have an online parenting program we call Parenting Smart Online, which is not dissimilar from actually something like what Triple P offers, but it has been very much developed from the experience and working with the children and parents within our schools. And then the third area I've mentioned already is working with school leaders, teachers and staff or trusted adults within the school environment, or even extending to sports coaches, youth workers, where we provide training based on their role. So it's not turning a teacher into a therapist, but it's about, in your role as a teacher, how you can support a child. And particularly active listening is a key part of that, but also your own well-being and self-care and how you are looking after your own well-being. So who do we reach? So the children that generally in the schools that we work with tend to be some of the more vulnerable children and young people. So in our primary, there you've got some stats in the primary age group, and then in the secondary school age group. In the UK, accessing pupil premium means that the child is from a family where there is around an annual income of £15,000 per annum or less. A percentage of the children are on the waiting list for specialist services. So either they're not able to access that due to waiting lists, or we are able to work with them and engage and provide some support before they can actually be seen by the child and the more specialist child and adolescent mental health services. And you also see that between 8 and 10% in the secondary were subject to a child protection plan. So that's where there are real safeguarding concerns around the child or the family where they are. One of the things that we've really worked on here at Place to Be over the last couple of years is actually really thinking about what is the right intervention for each child, recognizing the need to tailor approaches dependent on the issues that the child is presenting with. So this is just to give a flavor of, for our clinicians, the presentation that they're seeing from the child, whether that's conduct or hyperactivity. And then we have then skilled our clinicians, or in our local team have access to a Place to Be family practitioner, where we can then deliver our intervention, where we're coaching the parent and child together. I mentioned our CBT informed approach, which we've worked with the Anna Freud Center, another voluntary sector organization here around where children or young people present with low mood, depression or anxiety. And then Journey of Hope, which is the group work program, really, which is where children present with low self-esteem or have social or relationship difficulties, and where we think building a wider peer support network can also help with building greater resilience. In terms of our impact, so evidence and impact is something that's been inbuilt to exploring, which is both to look at and help us improve our practice, but then also to be able to share that learning on a wider scale, whether that is publishing in academic papers, informing policy, and just putting it out there to the wider world around what we are finding is working. And last year, we found that 78% of the children in primary schools had improved mental health on one or more measures after our weekly one-to-one support, and over 90% of young people in the secondary school age group had improved mental health on one or more measures. So this really makes a difference on that individual level for individual children. We know this targeted work is really effective. Another voluntary organization, Pro Bono Economics, did a study on our work, which looked at the return on investment over time, and that showed that for every £1 invested in our targeted work, it delivers an £8 return to society. So that is really the fundamental of the business case of invest early. This really does make a difference and saves funds in the longer term. Last year, not quite the same scale as you all in SAMHSA. Last year, we have provided services working directly with over 650 schools around the UK. So that's around Scotland, Wales, and in England. That's reaching a school population of 350,000 children and young people, and training in the last year almost 9,000 UK teachers and staff on our online programs. An interesting trend we're finding there is actually schools here. There's a bit of, I think, fatigue around the online programs. And I think a bit of a return we're finding from schools actually wanting somebody to come into the school so that you're creating time and space for the staff to actually stop and listen and think. So there's something there about the blended approach and how people are responding, or how people are finding some of the online tools and all the rest. And then finally, I just wanted to share a little bit about the way ahead, or part of what we're thinking in terms of longer term solution as we look across the landscape in the UK, which has changed. And we obviously now have mental health support teams doing more in schools, which is absolutely brilliant from within the NHS system. But similarly, we know that the challenge around availability of skilled workforce is one of the key constraints. So one of the things that we are really focused on right now is developing an apprenticeship standard, which is a new role within schools, and then an apprenticeship which can be accessed, where funding can be accessed for schools to train their own child mental health professional. So for a school to be able to have one of their own staff team train to be a skilled school or community-based counsellor who can do the sort of work that we do at Place to Be, but equally other training providers could also provide that program. This is key in terms of removing barriers to the cost of training as a child mental health professional, as a child counsellor. And it means that people who might not previously have thought that they could have either afford or that might not have seen themselves in a counselling or mental health role can actually get on a career path and can be trained up as school counsellors or child mental health professionals. And I think this is something that can really create capacity in schools for themselves to have their own person at a recognised standard, providing evidence-based support. And then finally, I just wanted to finish with words. This sits on my desk, actually. This is from a young person where we did where we did what we call a visit with some of our key stakeholders in one of our schools, where the children and young people talk about the service and what it means for them. So this is a little boy who's aged around 12, and this was his thoughts. When I go to Place to Talk, that's a 15-minute session that runs at lunchtime, I feel confident. I know that I can talk to someone I can trust. It was great to go. It was also useful. I gained more confidence and joy going there. So I think it's that word about gaining, it being useful, but also gaining more joy that really keeps me going. So there we go. So that's
Catherine,
our Place to Be story.
Thank Catherine. Thank you very much, and good to finish on confidence and joy. Nancy,
I have a question, and Catherine, I apologize if we have a new employee starting, and I stepped out to shake a hand and say hello. But did you talk about how long a child or a student can be with someone, you know, in the program? I realize that the lunch thing is probably voluntary, but how long they stay in there, and is there a way that you assess that they're able to be released and not have to be in there anymore?
Yeah, so the targeted work, so where we're doing the one-to-one counselling, for example, we do an assessment beforehand with the child, the teacher, the parent, and then we aim to work for up to 10 sessions. It's not hard and fast, and this is an interesting one in terms of Place to Be learning. It used to be much longer, and then we said, look, all the research and the evidence says, you know, that so much of the change happens in those early sessions. So with great challenge and with great over time, it took time and it took determination. Our clinical director and team, we really led a program which was based on the research to change that. And therefore we're able to deliver to more children in a targeted way with consistent outcomes. We've seen no drop in the outcomes. That's fabulous. With consistent outcomes.
One more question, because it's an issue for us here, parent consent. So do you struggle with kids that might really need this, but you can't get the parent to consent to, you know, I think we're allowed to do it's like up to 3 sessions with a child before you have to, you know, it's considered brief intervention, like as maybe for a crisis or something. And then after that, you have to get the parents. Do you guys have a challenge with that at all?
So this is where being embedded in the school and the partnership with the school is absolutely crucial. So we become very much a familiar face and a familiar part of the school. You also work with your counterpart in the school to think who's best placed to reach this parent. And then there's a thing that our clinicians will call it's hanging out at the school gate on a wet Tuesday afternoon, morning and after school. And just because listening, you know, our people, you know, clinicians are so brilliant at listening and being approachable and supportive, they just
Yeah.
work at it.
Yeah.
So
I mean, it's almost
sometimes
like you have to give the parent a little therapy before you can get to the child, which is it's all good stuff. It's all good stuff.
But I think we find that for the most part, what parent doesn't want the best for their child?
No,
And when you work at it, and the fact that it's embedded within the school and so familiar and part of the school system, that you can break down at those barriers. Sometimes it can take time, but
yeah.
So Catherine, I mean, did you have a question for Nancy or Jen in terms of what you were listening to with them?
I was interested in, so our world is across health, education, and often trying to bring funds together from both of those worlds. And that feels like a real headache, joining up systems, and I just wondered, in terms of your world, Nancy, is it clear health? Is it educate, or what route does it come down?
Yeah. So both. And you're right. We have to continually work on our relationships and collaboration with, I always say, Jen and I talk about, we expect in with our grantees that they must collaborate. They must have, if it's a school that's been awarded, a local education aid, a school district that's been awarded a grant, they must partner with a community health provider or behavioral health provider. They must partner with the state mental health authority. They must partner with the state education agency. Like, they have to make these partners, but yet we don't do it very well ourselves. So we have to constantly, depending on the administration, we may or may not have a great relationship and open collaboration with the Department of Education, with the Department of, that's the Department of Justice, that where juvenile justice sits. So we pretty much, I would say, if I were to give you an honest answer, we probably come down the health side. But so many of our programs in our division anyway are in schools that we have a very strong connection to education. And so sometimes we will bump heads with ed. We've kind of like come to an agreement that education, and we kind of overlap sometimes, and we kind of duplicate what we're offering. But that's okay. It's more money, more opportunity for schools to work. But ed will sometimes take the more school safety approach. So like metal detectors, or like they have more of that structural school safety and putting those policies in place. And we kind of have this unspoken agreement that we'll take the mental health side in schools. So, but it's a very fragile relationship and constantly needing massaging at the federal level,
Okay, thank you.
Yeah.
Jen, did you have anything you wanted to add to that?
You're on mute, Jen, if you're talking.
You should be able to
You're on
unmute
mute.
yourself. No? Oh,
You could drop it in the chat.
yeah.
Yeah, but you're right. Embedded in the school is Gold Star. I was very interested, and I kept thinking while I was listening to your program, like, ooh, we would love to fund you. We would love to give you a grant.
Oh, wow. Yeah.
What you couldn't do with $1.8 million a year, huh?
I know.
yeah.
Oh, Mamma mia.
I think we can hear you now, can we, Jen?
Yeah. So just the one thing I was going to add to what Nancy said is that we encourage grantees to blend and braid their funds. So if they have like a grant from another, Department of Ed or something, that we encourage them not to duplicate efforts and to really, use each grant for, what it
Wisely.
is for, but also collaborate and work together with those other grant programs. That was the one thing I was going to add.
And Peter has heard about this program, and Jen's heard it ad nauseum. But I go back to the days of, and I think I shared this with you, Peter, but I'm happy to send it out again, is we did have back in the day, after Columbine, that tragedy, that school shooting, there was a grant program that was created, Safe Schools, Healthy Students. And that, in my opinion, Catherine, was the blue ribbon model that was created, that was truly integrated. It was HHS, it was SAMHSA, Department of Ed, and Department of Justice. First time, I think, in our government's history that actually pooled human resources and money for one grant program. And we were able to tackle education, justice, and health all in this one grant program. And it was, I was actually a grantee. I was a PD, and then I later worked as a technical assistant specialist and then as a government project officer. It was a blueprint model of true integration and school-based services. The funding went straight to the school buildings. And it was brilliant. It was brilliant. It lasted about 10 years, and then they decided that they didn't want to do that anymore. And it's sad because those were programs that were that are to this day still sustained. In fact, the one that I was a project director for in Utica, New York, was a 1991 grantee, and they were only 3 years then. To this day, it still exists and is in that Utica City School District. So you're right. That's it. That's the magic of it. That's what has to happen. But it's just incredibly, incredibly difficult. And it has to be done up here. We all know that. In a school building, it works if you have your school leadership. If your school leadership owns it, champions it, they can make that happen. We know that. Not only buy-in, but ownership. People have to own those initiatives. But I really loved hearing about your program. That is really, that's like that almost, Catherine, if we could have you back just to talk to our trauma-informed support services grantees in our nation, that's an incredible trauma-informed support services model that schools could easily replicate, not easily, but could replicate, work to replicate it. If you're open to that, we would love to have you speak to our grantees about that model. That's great.
Very happy to, delighted
Yeah.
to just spread the word, make a difference. Absolutely happy to, Nancy.
Thank you. Well, I'll reach out to you.
Great.
Perfect.
That's really good. I mean, you both talked about workforce, and I was sort of wondering, given what we know about who is trusted and who is most trusted, and given what we know about what the outcomes are, depending on the relationship between the person seeking advice and the person giving advice, what does that tell us about what we need to do in terms of growing the right workforce and having the right people available?
Well, I think Catherine's model is brilliant. Your apprenticeship model.
I think the workforce has to reflect the communities. We've got to build from the ground up, reflect the communities that we're there to support. And those communities, I mean, they look very different in Glasgow to what they look in, central London to what they look like in Devon, rural coastal place. So being able to build a workforce with a quality assured standard, because we want to be sure that what somebody is doing is evidence-based to a standard. But we want to build capability in communities, not to have sort of, flying in, top down, dropping in. Building capacity from within, I think is so important.
And the apprenticeship model is the enabler. Absolutely,
because the apprenticeship model will remove the financial hurdle for an individual to train as a counsellor. So through the structures here in the UK, through that being funded, or through an employer being able to fund the training. And that really opens up. We know that's one of the key financial barriers to having a much more diverse and inclusive workforce.
At the federal level here, we have several multiple programs for workforce development. We have fellowship minority or minority fellowship programs. that specifically targets individuals that are in underserved populations or minorities, and create those pathways for them to get trained, educated, and then placed in the workforce. We also have another Pathways program where in the federal government, if you're a recent college graduate, you can get directly hired to the federal government and get your experience working as part of your learning. And we also have various internship programs, paid internship programs for college students. We also have experience. We have several in our division right now that are, let's say they're in their junior, senior years of college, and they're in this field, or they're interested in this field, and they work alongside us for like a semester or a school year while they're in college to like help. We, teach them, and it really just lights the fire, and then we get them in. So it is in various ways that we try to pay attention to workforce, but we have several programs that specifically, we have a whole agency, HRSA, the Human Health Resource, I never know what it stands for, but anyway, they do a lot of workforce training in building the capacity and providing training to workforce to build that.
Yeah, but I mean, but Jen, I was very conscious on your slides, the workforce remains a challenge.
You're muted.
Oh, I don't know. Not quite sure.
Yes.
Anyway,
we're still I could say we're still experiencing in the schools that are grantees. We still hear regularly that their teachers are burnt out. There's not enough clinicians. There's just not enough people. Caseloads are in the hundreds. I don't think it's any different anywhere in the world right now. It still is incredibly an incredible struggle, and we're trying to support them, provide them training, provide them emotional support, wellness support to get them, to rebuild that. But it's going to take a bit of time, I think.
Yeah. Listen, we're coming up to our time. Can I thank everyone for coming this afternoon? Can I particularly thank Jen, Nancy, Catherine, and Bron for their contributions? I think having that international comparator is really important, both in terms of actually the similarities in terms of some of the evidence base, but also what some of the differences are and how we might learn from each other, the things that each other is doing. So that was incredibly powerful this afternoon, and I really would like to thank you for the time both you put into preparing the presentations and to delivering them this afternoon. Thank you all for joining us. If you want to be part of the Global Network, if you want to make sure that you know about future events and future activities, please do go to the GLE website. I put the link into the chat, and join GLE. And the next network conversation is working with young people with a diagnosis of borderline personality disorder, and that's on the 28th of October, and we'll make sure that people have details of that. We will share all the slides. We will share the recording from this afternoon with everyone who attended. Thank you all, and enjoy whatever remains of the rest of your day, depending on where you are.